This podcast is brought to you by hepcidin, the molecular warden of iron. When inflammation sweeps through the body like an uninvited guest, hepcidin, a tiny but incredibly powerful hormone, is activated. Its mission? To act as the zealous gatekeeper of all iron, sealing off exit routes from storage cells like a medieval fortress. Iron, desperately needed by the red blood cell factories, finds itself trapped behind invisible molecular bars, creating a curious paradox, a body full of iron, yet suffering from its functional absence.
Welcome back to the Deep Dive.
Great to be back. Last time, we took a journey through the most common anemia on the planet, iron deficiency anemia. We unpacked how a simple lack of iron ripples through the body from the gut to the CBC printout.
We did, and we ended by promising to tackle its great imitator, the other heavyweight champion of anemia that you will see every single day in the lab. Today, we're talking about anemia of chronic disease, or as it's more accurately called now, anemia of inflammation.
It's the ultimate pretender. It can look like IDA at first glance, especially with that low serum iron. But if you misinterpret the pattern, you not only miss the diagnosis, you miss the much larger, often more serious, underlying story. And that's our goal today, to give you, the MLS, the high-resolution picture you need to differentiate these two conditions with confidence.
We're going to build on the foundation of iron metabolism we established in our last episode. We'll pinpoint the exact molecular switch that gets flipped during inflammation, and then, most importantly, we'll walk through the lab results, the CBC, the smear, and the crucial iron panel, and explain exactly why they look the way they do.
It's all about moving from memorizing patterns to understanding the pathophysiology. When you see a low serum iron with a normal ferritin, it shouldn't be confusing. It should tell a very specific story. So let's jump in. To set the stage, let's do a lightning-fast recap of the classic IDA iron panel. What's the pattern?
You got it. In true iron deficiency anemia, the body is desperate for iron, so the iron panel reflects that desperation. You have low serum iron, the circulating supply is gone, high TIBC, the liver pumps out transferrin taxis to scavenge for any available iron, low percent saturation, the few taxis on the road are mostly empty, and the linchpin, low serum ferritin. The storage warehouses are empty. That's the defining feature.
A perfect summary. Desperation is the key word. Now, let's pivot to anemia of chronic disease. The psychological state of the body is completely different. It's not desperation, it's defense. The body believes it's under siege.
What kind of siege are we talking about? What are the chronic diseases or inflammatory states that trigger this?
It's a huge category. You can think of it in three main buckets. First, chronic autoimmune diseases, things like rheumatoid arthritis, lupus, or inflammatory bowel disease like Crohn's. The body is in a state of constant low-grade immune activation.
Second bucket would be chronic infections, not necessarily a raging acute sepsis, but smoldering infections like tuberculosis, osteomyelitis, or even HIV.
Exactly. And the third bucket is malignancy. Cancers are notorious for creating a systemic inflammatory environment. So when a patient with one of these conditions develops anemia, your ACD alarm bells should start ringing. The common thread linking all of them is inflammation, and specifically, the release of inflammatory cytokines.
And that brings us to the master regulator we introduced last time. If there was one molecule that defined IDA, it was ferroportin, the iron door. In ACD, the story is all about the molecule that locks that door, hepcidin.
Hepcidin is the absolute star of this show. As a quick refresher, hepcidin is a hormone produced by the liver. Its only job is to find the iron export protein, ferroportin, bind to it, and cause it to be destroyed. High hepcidin means all the ferroportin doors slam shut and are locked.
In a normal, healthy state, hepcidin levels are modulated by iron stores. Plenty of iron, a little more hepcidin to say, we're good, slow down absorption. But in anemia of chronic disease, that feedback loop is hijacked. The primary signal driving hepcidin production isn't iron status anymore. It's inflammation.
Precisely. Cytokines, specifically interleukin-6, IL-6, are incredibly potent stimulators of hepcidin gene expression in the liver. A patient with rheumatoid arthritis, for example, has chronically high levels of IL-6. This tells their liver to turn out hepcidin 24/7.
And what is the physiological consequence of these chronically high hepcidin levels? Where does the iron get trapped?
It gets trapped in two critical locations. First, in the duodenal enterocytes. Remember, that's where we absorb dietary iron. Iron gets into the cell via DMT1, but it can't get out into the bloodstream because the ferroportin door on the other side is gone. So dietary iron absorption plummets.
Okay, so it blocks new iron from coming in, but what about the iron we already have in our bodies?
That's the second and arguably more important location. The macrophages of the reticuloendothelial system, primarily in the liver and spleen. These are our recycling centers. Macrophages phagocytize old senescent red blood cells to reclaim their iron. Normally, they would release that recycled iron back into circulation via ferroportin, so it can be used to make new red cells.
But with hepcidin on patrol, that ferroportin door is locked shut, so all that valuable recycled iron is now imprisoned inside the macrophages. This is the central event of ACD. It's not a true deficiency of iron in the body. It's a deficiency of available iron due to sequestration. The iron is in jail.
That is the perfect analogy. The warehouses are full, but the foreman has locked the doors and won't let any raw materials out to the factory floor. The bone marrow is being starved of iron, even though the body's total iron stores are normal or even high. And this single concept, iron sequestration driven by hepcidin, explains every lab finding we see.
Okay, let's make that connection directly. Let's bring it to the bench. A CBC from a patient with classic long-standing ACD arrives at your station. Let's start with the indices. What do we expect for the MCV?
This is a fantastic point, because ACD can be tricky. Initially, and in many mild cases, it presents as a normocytic normochromic anemia. The MCV will be between 80 and 100. The body is just generally suppressing red cell production. But if the inflammatory state persists for a long time, that iron restriction starts to really bite.
And when that iron restriction becomes the dominant problem, the marrow can't package enough hemoglobin into the developing erythroblasts. Just like an IDA, the cells undergo an extra division to try and maintain their hemoglobin concentration, and the resulting cells are smaller. So in about a third to a half of chronic cases, ACD becomes a microcytic anemia.
So you have to be ready for either presentation, normocytic or microcytic. But what about the RDW? In IDA, we made a huge deal about the high RDW from that mix of old normal cells and new tiny cells. What about ACD?
The RDW in ACD is most often normal. This is a hugely valuable clue. The inflammatory process creates a steady, uniform suppression of erythropoiesis. All the cells being produced are more or less equally, though poorly supplied with iron. There isn't that chaotic, starved production you see in IDA. So you get a homogeneous population of either normocytic or microcytic cells, leading to a normal RDW.
So right there on the CBC, you have a major clue. Microcytic anemia with a normal RDW should make you think less about IDA and more about ACD or thalassemia trait. A high RDW points you strongly towards IDA.
What about the peripheral blood smear? In IDA, we look for those characteristic pencil cells. What does the morphology in ACD tell us?
Honestly, the smear in ACD is often disappointingly nonspecific. You'll confirm the analyzer's findings. You'll see either normocytic normochromic cells or, in chronic cases, some mild microcytosis and hypochromia. But you don't typically see the dramatic poikilocytosis like pencil cells or the striking anicytosis that you see in IDA. The most significant finding on the smear is often the lack of a dramatic finding.
Let's move to the bone marrow's response. What is the reticulocyte count doing? The body is anemic, so is the marrow trying to compensate?
It wants to, but it can't. The reticulocyte count will be low or inappropriately normal for the degree of anemia. The reticulocyte production index will be less than 2. And there are 2 reasons for this, which go back to the pathophysiology. Reason 1 is the one we've been hammering home: iron-restricted erythropoiesis. The factory has no steel.
So it's a hypoproliferative anemia due to lack of raw materials. What's the second reason?
The inflammatory cytokines like TNF-alpha and interleukin-1, in addition to stimulating hepcidin, also have a direct suppressive effect on the bone marrow. They can blunt the marrow's response to erythropoietin, EPO, the hormone that tells it to make red cells. In some cases, they can even slightly suppress EPO production from the kidneys. So the marrow is getting hit from two sides. It's not getting the raw materials it needs, and the go signal from EPO is being muffled.
A double whammy, no supplies and a weak production order. That paints a very clear picture of why the retic count is low. Now, for the main event, the physician sees this normocytic or microcytic anemia with a low retic count, and they order the iron panel to differentiate it from IDA. Let's walk through that panel test by test and explain the why.
Let's do it. First up, serum iron. What do we expect?
Serum iron will be low. This is the red herring. This is the result that makes ACD look like IDA. And the reason is simple. High hepcidin has locked the iron away in the macrophages and blocked it from being absorbed. Therefore, the amount of iron circulating in the blood on transferrin is low.
Exactly. The test is accurate, but it can be misleading if you look at it in isolation. So we move to the next test, total iron binding capacity, or TIBC. This is an indirect measure of transferrin. What's the liver doing?
In IDA, the liver sees the iron desperation and cranks out transferrin, so the TIBC is high. In ACD, the body is actively trying to hide iron. There is no signal of desperation. In fact, transferrin is a negative acute phase reactant, meaning its production can decrease during inflammation. So in ACD, the TIBC will be normal or low. This is our first major point of differentiation from IDA.
Beautifully explained. The body isn't sending out more empty taxis because its goal isn't to find iron. Its goal is to hide it. Now let's look at the transferrin saturation, which is just serum iron divided by TIBC.
The math on this one can be tricky. You have a low numerator, serum iron, and a normal or low denominator, TIBC. The resulting percentage will often be low or low normal. It can fall into that 10 to 20% range. So like serum iron, the percent saturation alone can sometimes be ambiguous.
Which brings us to the tiebreaker, the single most important test to differentiate IDA from ACD, serum ferritin.
This is the game changer. Remember, ferritin is not a measure of circulating iron. It's a measure of stored iron. It's a tiny window into those massive iron warehouses in the liver and macrophages. In ACD, are those warehouses empty or full?
They are full to bursting. The problem is that the iron is locked inside. Therefore, the serum ferritin level, which reflects these stores, will be normal or high. A ferritin level above 100 nanograms per milliliter in an anemic patient essentially rules out pure IDA and makes ACD the leading diagnosis.
Let's put that whole beautiful logical pattern together. The classic iron panel for anemia of chronic disease is low serum iron, low or normal TIBC, low or normal saturation, normal or high ferritin. It's the mirror image of the high TIBC and low ferritin you see in IDA. Understanding the role of hepcidin makes this pattern make perfect sense.
And just to complete the diagnostic picture, what other lab tests might support a diagnosis of ACD?
You'd want to look for evidence of the eye in anemia of inflammation. You would expect markers of inflammation to be elevated. An elevated co-reactive protein or a high erythrocyte sedimentation rate, or ESR, provides context and confirms that the patient is in the inflammation state that drives hepcidin production.
Fantastic. Now let's throw a wrench in the works because the real world is messy. What happens when a patient has both? A patient with long-standing rheumatoid arthritis who also develops a slow GI bleed. They have ACD and superimposed IDA. How does that tangled picture present in the lab?
This is the toughest diagnostic challenge, and we see it all the time. The inflammatory state of ACD will drive ferritin up, while the iron deficiency will pull it down. The result is that the ferritin often lands in this indeterminate gray zone, somewhere between 30 and 100 nanograms per milliliter.
So a ferritin of 60 would be high for a normal person, but it might actually be masking an underlying iron deficiency in a patient with active Crohn's disease. The TIBC can also be confusing, sitting in the normal range. It's a tug of war between two opposing signals.
In these really ambiguous cases, we might need more advanced testing. The test for the soluble transferrin receptor, STR, can be very helpful. The STR is a piece of the transferrin receptor that's shed from cells into the plasma. When cells are starved for iron, they put more transferrin receptors on their surface to try and grab more.
So in true IDA, STFR levels go up. But in ACD, where the problem is iron utilization and not a true lack of iron, the STFR level is typically normal. So in that confusing combo case, an elevated STFR would point towards a coexisting true iron deficiency.
The STFR to log ferritin ratio is an even more powerful tool, but the key takeaway is that when you see a gray zone ferritin in an inflamed patient, you have to be suspicious that you might be looking at a mixed picture.
So let's bring it all home. As an MLS, you see a CBC with a microcytic or normocytic anemia and a normal RDW. The iron panel comes back low iron, low TIBC, and a ferritin of 150. You also see on their chart that the CRP is high. What is the story you're reading?
You're reading the story of hepcidin. You're seeing a body that's hunkered down for a fight. The high CRP tells you inflammation is present. That inflammation has triggered the liver to produce hepcidin. Hepcidin has locked down ferroportin, trapping iron in the macrophages. That's why ferritin is high. Because it's trapped, it can't get into the blood. That's why serum iron is low. The body isn't desperate, so it doesn't make extra transferrin. That's why TIBC is low. And the bone marrow is being starved and suppressed. That's why the patient is anemic.
And that diagnosis has huge clinical implications. The treatment for IDA is iron, but giving oral iron to a patient with pure ACD is mostly useless because hepcidin will just block its absorption. The treatment for ACD is not to treat the anemia directly, but to treat the underlying inflammatory condition. Our lab results guide that entire therapeutic decision tree.
It's a perfect illustration of our role. We're not just reporting that the ferritin is 150. We are providing the key piece of evidence that distinguishes a state of iron deficiency from a state of iron sequestration. It all comes back to the why.
Couldn't have said it better myself. By understanding the central role of hepcidin, the seemingly contradictory results of the ACD iron panel become perfectly logical. It's not a paradox, it's physiology.
A great place to wrap up our discussion on the great pretender. We've unmasked anemia of chronic disease, and with that we've now covered the two titans of microcytic anemia that revolve around iron. But there's a third major entity in that differential that every MLS needs to know inside and out. On our next episode, we'll continue with the microcytic anemias.
So we're not moving on from microcytes just yet. You must be talking about the inherited anemias, where the problem isn't the iron at all, but the other half of the hemoglobin molecule, the globin chains. You mean thalassemia.
Exactly. It's a production problem of a totally different flavor. Not a lack of supplies, but a defect in the factory's genetic blueprint. We can dive into why the red cell count is often paradoxically high, why the RDW is often normal, and what the story is behind a smear loaded with target cells and basophilic stippling.
That's a perfect plan. It will round out the complete differential for the most common RBC morphology we see, from a supply problem in IDA to a lockdown warehouse in ACD to a faulty blueprint in thalassemia.
I love it. We'll see you all next time on The Deep Dive.